righty, well, hello and welcome back to the MDA Engage Pediatric Care Seminar. I would now like to introduce our next speaker, Dr. John J. Parent. Dr. Parent currently serves as the Medical Director of Pediatric Cardiac Transplantation, Cardiomyopathy, and Advanced Heart Failure. He received his degree from Indiana University School of Medicine, where he also went on to do his pediatric residency and pediatric cardiology fellowship. During his pediatric cardiology fellowship, he obtained his Master's of Science in Clinical Research from Indiana University. Following his pediatric cardiology fellowship, he went on to do one additional year of training at Cincinnati Children's Hospital Medical Center in the areas of cardiomyopathy, cardiac transplant, advanced heart failure, and mechanical circulatory support. During his training in Cincinnati, he trained under many of the field experts in these areas. He is certified by the American Board of Pediatrics in Pediatrics and Pediatric Cardiology. Dr. Parent has a particular interest in inherited forms of cardiomyopathy, including those associated with various muscular dystrophies. His research focuses on the genetics and treatment of cardiomyopathy, with a particular interest in left ventricular non-compaction cardiomyopathy. He has presented his research at regional, national, and international meetings. We are happy to have Dr. Parent present today. And with that, I will hand it over to you, Dr. Parent.
Thank you, Kristen. I appreciate it. Can you hear me well? Great. Let me just share my slides quickly here. Well, good. Again, thank you for the invitation to speak. I really like giving talks like this. I kind of think of this talk as a talk of what it would be like to be in clinic with a pediatric cardiologist in a neuromuscular clinic over the years of a patient. And so there's a lot of information here, but I try to hit the highlights on sort of all the subtopics. And one little caveat is a lot of this will be focused on Duchenne muscular dystrophy, but a lot of the philosophies and treatment strategies really extrapolate to all types of neuromuscular disease. And so I want everybody to sort of keep that scope as they sort of listen to this talk, that this can apply to really all sort of neuromuscular diseases. Just how we focus in from a cardiology perspective kind of determines on the specific type of neuromuscular disorder that the patient has. And so the name of my talk is Taking Care of the Heart with Neuromuscular Disease. I have no financial disclosures. I am a site primary investigator for 3 studies that do involve patients with muscular dystrophy, but I do not receive any sort of compensation for that. And so as cardiologists and people who take care of patients with neuromuscular disorders, we sort of break the heart down into 3 categories of how we're monitoring it. And I sort of think of the heart as function, meaning the squeeze of the heart, how well it sort of squeezes and pushes the blood out to the body. Relaxation, our fancy term we have for that is diastolic function, is the heart relaxing healthy so that it can refill with blood and so it can prepare itself for the next cycle to push the blood out. Another subcategory in the heart that's fairly unique to muscular dystrophy and is found in a few other types of heart disorders is scar tissue. So fibrosis or scar that can develop between the heart muscle cells can actually cause damage to the heart and cause clinical issues for the patient. And finally, arrhythmia, a term we use to say a patient's heart is going abnormally fast or abnormally slow and can cause issues. So if we break the heart down into sort of those 3 categories, sort of most of my talk will sort of focus on how we monitor each of these categories and how we can treat each of them if they become abnormal. And so I think a really important thing to sort of know, and again, this is just for Becker and Duchenne patients, this sort of graph, but there can be a similar graph for all types of neuromuscular disorders. But if you think, if you can see my cursor here, each one of these is sort of a cell of a heart muscle, and our heart is made up of billions of heart muscle cells. And so each one of these looks like this if you sort of cut it open and looked at it under a high power microscope. And if you look, the heart muscle is really made of various types of protein that have to work in sync through each heart cycle. So 60 to 180 time beats a minute. And so if one of those proteins become abnormal, you could imagine how the heart muscle might become abnormal and the heart function or rhythms could be abnormal over time. And so if you look here, the green sort of snake-like protein that's going through here is dystrophin, and that's the protein that's abnormal in patients with Duchenne muscular dystrophy. And the purpose of this protein, as best we understand it, is it anchors this heart muscle cell to sort of the glue between these billions and billions of heart muscle cells throughout the heart. And you can imagine if this protein is dysfunctional or we don't have enough of it, those heart muscle cells aren't anchored to that glue and over time might become weakened, or they might not communicate from cell to cell electrically, and so we can develop electrical problems. One way to look at heart involvement in Duchenne's is really just the squeeze of the heart, although that's not the only focus. But if you look at how prevalent is heart involvement in patients with Duchenne muscular dystrophy, and this is over the years. So if you take a patient with Duchenne muscular dystrophy who's less than 5 years of age, very rare that you're going to see any heart involvement. And as they get older and older, as you can imagine, and time develops more problems with the heart, it becomes as prevalent of 75 to 90% of patients over the age of 20 years are going to have heart systolic dysfunction, and probably even more with other types of heart dysfunction. And so as we educate families in the clinic, we almost say there's an expectation at some point your heart is likely going to see some involvement, and we need to monitor for that so that when we find involvement, or if we can find ways to prevent involvement, we can act on that with either medications or lifestyle changes. And so how do we monitor that? I think two ways, big picture that we look at things is imaging. So how can we take pictures of the heart to see how functionally well it's performing? One, I'm sure a lot of you have seen in clinic is an echocardiogram. So that's utilizing ultrasound waves to look at the heart. And a newer technology in the last 15 to 20 years that has been very helpful in patients with heart disease, specifically those with muscular dystrophy, is MRI. And I'll talk to you why that has some added benefit in these patients. And another way that we monitor is for rhythm disturbances. And I'll talk about all the different tools we have as cardiologists to monitor and treat rhythm disturbances. So first, let's look from a functional standpoint. So again, when we're looking by echo, we can see the structure of the heart. And usually the structure of the heart is normal in patients with muscular dystrophy. Certainly we could find mild abnormalities and we would talk to you about that. But for most patients, we're talking about monitoring the squeeze and the relaxation of the heart. And so the picture on the left here is the left ventricle. So if you see, this is the left ventricle here. The mitral valve, where the red arrow is the valve that lets the blood from the lungs into the heart. And the aortic valve up here is the valve that lets blood out of the heart. And so when the heart is relaxing, we like to see blood fill this heart with all this heart muscle relaxing nice and healthy. And remember, this heart muscle here is the muscle that's made up of those billions and billions of heart muscle cells that if they have a protein abnormality like a dystrophin abnormality can become dysfunctional. And so when we see a nice healthy heart, we like to see it relax fully. And then the picture on the right shows the heart squeezing down. And as you can see, the blue arrow represents how well the heart squeezed down. And that blue arrow is much smaller than the blue arrow on the left because this heart is squeezing completely normally and pushing the blood out the aorta through the red arrow. And so we can use various types of modalities, ultrasound waves, and techniques to sort of determine the health of the heart during an echocardiogram, which can happen in the office. And as you probably know, takes anywhere from 10 to 30 minutes to perform and gives us really good information that we can see essentially in real time and then talk to you in the clinic about what we see immediately afterwards. And so that's why echo is a really nice tool. Over the last 15 to 20 years, though, we've done more and more research about cardiac MRI. Now, cardiac MRI is also a very good tool. It takes a little longer, and most patients need IV to be placed during the procedure to inject contrast into their veins so we can sort of light up the heart muscle cells to evaluate them better. And so the MRI is a very good tool, but does come with some downsides in the fact that it takes longer, requires an IV, and some patients can't lay comfortably for the time period it takes to perform the MRI, or it can become very claustrophobic. And so we utilize this when we can, which most patients can tolerate it, but we certainly don't want to force anybody to do an MRI if they're not capable of doing so. Again, MRI, just like echo, can show us information such as the squeeze and relaxation of the heart. But one added benefit, why it really benefits our patients with neuromuscular disease, is it can tell us scar tissue. And as you can imagine with patients with muscular dystrophy like Duchenne, their skeletal muscle becomes scarred over time, and that's what makes it become more dysfunctional as those skeletal muscles start to deteriorate and scar down. Well, that same process can happen in the heart and cause problems. And so to highlight that, this first picture on the left is actually a cardiac MRI looking at the heart as if it was sort of sliced through like a loaf of bread. And so this would be the left ventricle, the right ventricle, and the wall that divides them. And the simple way to look at this is the healthy heart muscle would be all of this black here. And so you can see all of this is healthy heart muscle. All of this in the right ventricle is healthy heart muscle. But as we look sort of in this area, we see a lot more white, and that arrow's pointing to that. And that is heart muscle that's been replaced by scar tissue. And if we looked at that underneath a microscope, what that would look like is healthy heart muscle cells would be your dark pink cells with the nucleus, which is sort of a purple blue. And then scar tissue is this light pink stuff that's sort of in between those heart muscle cells. And this would be sort of early to middle disease. And then as you go farther to the right, you can see a lot more scar has sort of replaced a lot of those healthy heart muscle tissues. And if you sort of think of it, this heart muscle now has made up of a lot of this scar, and that scar can prevent these heart muscles from relaxing fully or squeezing fully, or they can be areas where heart rhythms can develop sort of out of the blue. And so I think this is an important concept to know, is this is why the heart gets affected in patients with muscular dystrophy and what we can look for. And so ultimately, turning our attention to electrical, we're also looking for similar abnormalities that are caused by the same process, just manifesting in a different way. And so what we're monitoring for are fast heart rhythms, slow heart rhythms, or rhythms that can make our heart function become impaired because it's impairing the coordination of how well that heart muscle squeezes. And ultimately, why does this matter? Well, first, it matters because it can cause symptoms for the patient. So if you go into a fast or slow heart rhythm that's too fast or too slow for the activities you want to do, you can become fatigued, you could pass out suddenly, or you can simply feel palpitation or a discomfort of your heart racing or beating slowly. That can be very discomforting. Secondly, it can start to affect how well our heart is squeezing. Thirdly, areas of the heart where the heart function is not well and the heart is beating very fast or inefficiently, clots can develop in them. And if clots develop in the heart, it could squeeze those clots out and could go to various parts of the body and cause strokes. And then finally, the biggest thing we worry about is heart rhythm issues that come on suddenly that can cause a patient to die suddenly because they're not getting enough blood out to their body that causes them to suddenly faint and to not come back. And so that's why the rhythm portion of muscular dystrophy is equally as important as the functional portion of the heart. And so how do we monitor that? I think a lot of you are familiar with the EKG or ECG that we do in clinic, which is a great tool. And if you look down here, this is sort of a normal EKG in a person where each one of these sort of cycles is a heartbeat. And if we break down each one of those heartbeats, we can see this first bump here is the upper chambers firing normally, then communicating with the lower chambers, which is the big blip here. So as you can imagine, the ventricles are the most massive part of the heart, and so they put off the biggest electrical signal. And so the upper chambers fire, the lower chambers fire, and then everything resets itself, and then it gets ready for the next heart cycle or the next heartbeat. So the EKG is a very good tool to look for baseline abnormalities to let us know if there's any changes in a patient over time. However, it's only about 12 seconds of a patient's life. And so it doesn't tell us necessarily what the patient's doing at home on a day-to-day basis when they're sleeping, when they're being more active, when they're excited playing video games, or when they're calm watching a movie. And all of that is very important to know for the electrical health of the heart. And so what you might see is we might periodically do what are called Holter monitors, which is like a take-home EKG that you wear for anywhere from 24 to 48 hours or sometimes longer, where we can look at the heart rhythm throughout a day or two of a patient and make sure that we're not seeing any abnormalities in this process over a longer period of time. Another sort of version of this is called an event monitor, and that's a monitor a patient can take home and wear for 30 days, or really as long as you allow them and the insurance company allows them, but typically 30 days is the most common time frame we'll give for a patient. This is very good for a patient who is having symptoms of racing heartbeats, but we haven't been able to capture them. And the reason it's helpful is because they can wear the EKG and it doesn't necessarily monitor them 24/7, but if they feel a symptom coming on, they can hit a button on it and it will record an EKG for them and transmit that to us as the physician so we can look at it and say, okay, you're feeling this palpitation or you're feeling this abnormality in your chest, but we have an EKG to show that your EKG is normal, so we can provide them reassurance. Or alternatively, we can say, you're feeling this abnormality and we're actually seeing a fast or slow heart rhythm that requires treatment, and we're very glad that we caught this on the monitor. And probably the last one to monitor things that is even more long-term is what's called an implantable loop recorder. And that's sort of pictured over here to the right. And as you can see, it's being held in the palm of this person's hand. It's about the size of a paperclip these days. And it would be implanted usually in the office or in the cath lab setting, and it would go just underneath the skin through a small incision and sit underneath the skin and would actually monitor your heart rhythm 24/7 and send in to us when it finds abnormalities. And it's called a loop recorder because it will record for a period of time. And if we don't get any useful data off of it, it will sort of erase itself and then start the process over. And this loop recorder can be in patients for several years, even up to 5 years or longer if the battery life allows. It can be very good for a patient where we still have a high suspicion something abnormal is going on, but we haven't been able to capture it on an EKG, a Holter, or an event monitor. And we want more time and more data to sort of determine whether or not an abnormality is present. And so that's the two ways we focus on monitoring the patient. Now I'm going to turn to treatment. And so I want to break this down into 3 categories for treatment. One is prevention, which there actually are some strategies to help prevent heart disease in patients with muscular dystrophy. Another category I think of is active treatment. So once we find disease, what can we do to treat it to help either mitigate or slow its process over time so that the patient can live a better quality of life and hopefully a longer life. And then finally, advanced therapies is a category I think of is when all of our other treatments have failed, is there anything else that we can do for the patient that might be more invasive or more involved that could help them survive longer or feel better? And so first of that category is prevention. And so just like any patient that goes to a primary care doctor or to a group of doctors, including those with heart disease, we worry about a handful of categories. Number one is certainly blood pressure. Blood pressure has been shown time and time again over decades to cause increased strain to the heart. And if you have a predisposition for your heart to become weak or develop arrhythmias, blood pressure can push that over the limits. And so we always want to make sure our patients with muscular dystrophy have normal blood pressures for their age. And so that's something we check regularly in the clinic. Also not mentioned here is as patients with neuromuscular disorders are living longer and longer into their 20s, 30s, 40s, and 50s, cholesterol, high lipids, all of those can actually become a problem later on too. And we really want to watch for those as a risk factor for developing or exacerbating heart disease down the road. A second category, and I know we have a talk about this later, which I think is a huge piece to the heart, is optimizing nutrition. And this really goes both ends of the spectrum. We have patients with neuromuscular disorders who become less and less active because they become less and less mobile, and obesity can become a huge problem. Couple that with taking medicines that make people more prone to obesity, and then things start to become this vicious cycle, and all of that can become more pressure and more strain on the heart. And so really watching our overall eating health and our overall nutrition from that perspective can really reduce the strain on the heart, and that really adds up over the years and decades as patients are living longer. Next is malnourishment. So equally, we occasionally find patients with neuromuscular disorders who are in what we call a catabolic state, where their body's actually malnourished to the point they're breaking down crucial fats and proteins. And as you've seen earlier, the heart is made up of proteins, and we do not want it to be negatively affected or malnourished. And so having a healthy diet that's well balanced actually can help your heart health as well. And a big piece of why we do a lot of these multidisciplinary clinics is not only talking to the neurologist, but us being able to work hand in hand with the lung doctors, because respiratory health is very key to heart health long-term. As we say, they live in the same neighborhood. The hearts and the lungs are both in the chest, and they really work hand in hand to move blood, oxygen, and nutrients throughout the body. And so if your respiratory system is unhealthy because you have poor ventilation, meaning you're not getting oxygen in or you're not removing carbon dioxide out, that can start to cause strain on the heart. And a more advanced portion of that could be sleep apnea, where you periodically don't breathe deeply enough or forget to breathe while you're asleep. That can build up over time and cause strain on the heart. And ultimately, what we worry about is an entity called pulmonary hypertension, or high blood pressure in the lung arteries, that can start to cause end-stage problems for both the lungs and the heart. And this is what we're trying to prevent, both with our lung and our heart doctors working hand in hand. So prevention is actually very important in these patients. Another medicine I sort of think of as a preventative from a heart perspective is steroids. Obviously, we use these widely in patients with Duchenne muscular dystrophy, prednisone and deflazacort being the names you're probably most familiar with. And a lot of people ask, well, we do this to preserve their skeletal muscle and their breathing muscle health over time, and there's good data to show that these medicines do that. but there's actually as good data to show that they can actually reduce or delay the onset of scar burden in the heart, preserve heart function, and reduce the mortality of these patients with muscular dystrophy. And these are just a couple of probably 24 landmark studies describing how steroids have actually benefited the heart in patients with muscular dystrophy. The first one came out in 2013 when I was a fellow, and I just remember what sort of a landmark study this was and how cool it was to see, hey, we're finally doing some good things for the hearts in this patients and helping them live longer, which is a great thing. Other medicines you might see us utilize in clinic are ACE inhibitors or ARBs. Names you might know for ACE inhibitors are enalapril, lisinopril, captopril. A cousin medicine to this are angiotensin receptor blockers, or ARBs for short. Those medicines would be valsartan and losartan, typically reserved for patients who can't tolerate the first class of medicine because they develop a cough or other side effects. Both are equally good and equally effective from a heart perspective, in my opinion, and from research data that's out there. And so I don't want you to remember this whole slide because it can be pretty complex, but I think this slide really helps highlight how these medicines work. And so when we start to develop heart failure because our heart is not functioning well, what happens is our body starts to produce hormones to sort of counter that and try to benefit, but it actually causes more damage to the heart. And so this is the list of all the damage when we go into heart failure that can happen in our body as a result of it. And so what happens is your blood vessels start to constrict and start to get thickened. Your kidneys hold on to sodium. Your heart muscles start to get thickened and die. Your brain starts to release more adrenaline that can cause your heart to race and other things. And so how these medicines work is the main process that happens is renin is the hormone that's upregulated or increased when you go into heart failure. And it causes this enzyme to go to this enzyme, which causes all these problems I just talked about. Well, these medicines, ACE inhibitors, block the process of this becoming the end product of bad called angiotensin II. And so these medicines help prevent all this downstream damage. Similarly, ARBs do the same thing. They just block one step downstream, again, with the goal to prevent all of this badness. And so these medicines are very helpful in heart failure. Entresto, which is a newer heart failure medication, was FDA approved in adults in 2015 and in pediatrics over 1 year of age in 2019, is actually an ARB coupled with another new medicine called sacubitril. So it's a combination medicine. Although we think this is a great medicine, there is some limited data in muscular dystrophy, so it hasn't been well studied in that population, but it has been studied a little bit, and we think it's reasonable to use. It may eventually replace ACEs and ARBs in patients with muscular dystrophy altogether, but we don't know that yet. And so right now, I think all of these medicines are equally good. ACEs, ARBs, are Entresto. All of these medicines are good, and most patients are typically just on one of these medications, not 2 or 3 of them, as sort of coupling these together can be dangerous. The next category of medications you might see a patient or your child on is beta blockers. Typical names are metoprolol, carvedilol, atenolol is another one I don't have listed here. And again, going back to our diagram, is how do beta blockers work? Well, they block one of the processes where adrenaline can sort of be shot up in patients who go into heart failure, and they try to quiet that process down by blocking that procedure. And just a more advanced slide of that, if you think about it, as your heart starts to get damaged, the squeeze goes down, you start to release more adrenaline, that starts to cause your heart muscle to get more damage, counterintuitively, more scar tissue, and beta blockers can sort of mitigate or reduce that process. A hot topic in patients with muscular dystrophy is our aldosterone inhibitors. Common names are aldactone or spironolactone, that's the same medicine, or eplerenone is a similar medicine, all in the same class. And how aldosterone inhibitors work is sort of block some of these processes over here. So same diagram, but blocking some of the downstream effects of this bad guy called angiotensin II. And this medicine is very helpful. I think I have it on the next slide here, is it's been shown to helpfully reduce scar burden in patients' hearts with muscular dystrophy. And so it has some added benefit to some of the other medications we talked about. Now turning the page to advanced therapy. So those are medicines, obviously, we can take once or twice a day in pill form or liquid form. Very easy to use. They do have some side effects, but most of them are tolerated, or if we develop side effects, we can do lower doses or sort of different medicines in the same class to sort of get those. But those are medicines we have patients on typically in their teenage years and can be on those medicines for decades and decades. Well, the question comes up, well, what if these medicines start to fail? What else do we have in our cabinet of therapies to offer patients? And so here's just a list of them, and I'll talk about these each briefly, but ICDs are implanted sort of defibrillators that can shock you out of rhythm when you go into a fast heart rhythm. Pacemakers, ablation, I'll talk about, ventricular assist devices, and heart transplant as well. And so ICD is a device that we typically put in patients who have very low ejection fractions or squeeze of their hearts, or they have a history of known fast heart rhythms that weren't controlled on medicine. So we found them on one of those monitors we put on the patient earlier. We tried medicines first, but they're still having a lot of these fast heart rhythms, and we feel like these fast heart rhythms could become even more dangerous with time. A patient might have an unexplained passing out spell that worries us that it was a rhythm thing that we did not catch. Or of course, they had a history of a sudden cardiac arrest and were resuscitated by somebody because there was an AED or CPR was performed, or they were in the hospital around medical care providers who resuscitated them. Those would be sort of patients that we would identify as possibly benefiting from an ICD. And this has actually been studied recently, just out last year, was what have we done in the past with ICDs in patients with Duchenne muscular dystrophy and severe left ventricular dysfunction. And people have utilized it successfully, but we really like to make sure we only do it in patients who would truly benefit from it and not have any harm from it. So we pick a select population. And so how it works is it's monitoring your EKG all the time because it's implanted usually under the skin and muscle in the left upper chest, but sometimes under the left arm. And there's a wire that goes into your heart that monitors your heart rhythm all the time. And so it's basically constantly looking at your EKG. And if you go into a fast heart rhythm like this, as you could imagine, this patient's heart rate on the left would be 60 beats per minute, which is healthy and good. This patient's heartbeat would be 300 times a minute, which would be fatal if they stayed in that for more than just a few minutes. And so this ICD can identify this abnormal rhythm and provide an electrical shock to the heart to reset this and get it back to this rhythm as our hope. And so as you can see, this can be a very life-saving therapy for patients. Similar along the same lines as pacemakers. Not only do we worry about fast heart rhythms, but we worry about slow heart rhythms. So if you look at the EKGs on the bottom again, a normal EKG, upper chambers communicating to bottom chambers, resetting, upper chambers, bottom chambers, reset. Compare that to the EKG on the right, upper chamber here is firing, but there's no lower chamber. The lower chamber later on does its own thing, upper chamber firing, doing its own thing. Well, there's no communication between the upper chambers and the lower chambers. And as a result of this, this patient's heart rate is much, much slower, around 30 or 40 beats per minute, which could cause us to pass out, to have very low energy, or in some patients can even cause sudden death. And so if we identify a abnormal EKG like this, we might place a pacemaker, which can actually be implanted very similarly to how the ICD is, and then can start communicating these upper and lower chambers better and prevent these problems that we're seeing. And another benefit of pacemakers, I won't go into too much detail, is when sort of the heart rhythm between the two bottom chambers is not communicating well, the heart can start to contract less and less well, and sometimes pacemakers can override that abnormality and get the heart functioning better. And so there's another indication for pacemakers in some patients. Another category is ablations. That's where a catheter-based procedure is performed, and a catheter has gone up through the groin, through a vessel in the leg, traced up to the heart, and we can identify where that potential fast heart rhythm is and apply either heat or shock to that area and prevent that area from becoming a problem in the future. Another category is ventricular assist devices. I don't want to go into too much detail here, but we have temporary and permanent ones. These are devices that can be placed for patients whose heart squeeze is so low they're not getting enough blood out to their body. These would be patients in an intensive care unit initially, and this would be a way to get more blood out to the body. And we can place temporary ones to see if they can recover on their own. One category for that would be patients with like myocarditis or inflammation of the heart that needs time to recover. And once it recovers, this device can come out. Alternatively, permanent ones can be placed for a patient for the remainder of their life or as a bridge till they get a heart transplant. And so here's just a look at a temporary one called an Impella. This is a device that would be put in through a vessel in the groin, traced up through the aorta and placed into the heart here. A motor rotates through here and pulls blood out of the left ventricle that's not pumping well and puts it into the aorta or the body artery to get the blood out to the body so that this patient has a good blood pressure and can get enough oxygen and nutrients to their organs. Other modalities are ECMO and PDMAG, CentroMag, which I don't have highlighted here. Other options are permanent ventricular assist devices. These are surgically implanted in a patient with the goal to get them home. This is the HeartMate 3, which is one of the more common ones placed these days. This would be the pump here placed in the patient's left chest with a cannula going into the heart to pull blood out of the heart and put it into the aorta, again, to bypass the failing heart pump. The only thing sort of coming out of the patient's body would be a drive line, which is about a pencil width cord that would come out of their upper abdomen, hook up to a CPU that can be connected to batteries or to a wall unit that's plugged into the wall. And again, this diagram here just highlighting the cannula that pulls the blood out of the heart and then pushes it out to the body. Some people ask on occasion about heart transplant. So when all else fails, what has been done in the past for heart transplants in patients with muscular dystrophy? If you look, there's been almost 42,000 heart transplants for cardiomyopathy over a approximately 30-year time span up to 2016. Only 81 had been done for patients with muscular dystrophy, the most common of that being Becker and a few others. And if you look, only 3 patients with Duchenne muscular dystrophy have been transplanted. And so I like to think this is an option in some patients who have end-stage heart failure with muscular dystrophy. But there is this fine sort of window when a patient is sick enough to need a heart transplant, but not so sick that they're not a candidate. And so we have to make sure the rest of their body is healthy, meaning that their lungs, their kidneys, their liver are healthy enough to accommodate a heart transplant, because the goal is to get them to live several years longer. If we do a heart transplant in somebody and they only live 3 or 6 months after heart transplant, there's a lot of things that they have to go through for recovery that 3 or 6 months is not a good enough outcome for them. We want them to live years and years. And if we don't feel like we can get that outcome for them, they might not be a good candidate for a heart transplant. But the short answer is patients with muscular dystrophy have been successfully heart transplanted. Again, it relies on careful patient selection, making sure that their skeletal muscle isn't going to have a worsening stress during transplant that could put them on a ventilator permanently. And we always have to know that there's limited donors and hearts. And so we just have to be very thoughtful of which donors that we select for which patients. And as a result of that, patients that can actually die on the heart transplant list. And that's something we deal with on a regular basis. One other topic of medicine, and I'll sort of start finishing up here, is exon skipping medications. People always wonder if this is going to benefit the heart. And the short answer is we're hopeful. We just don't know yet. And so if you've heard of exon skipping medicines, I sort of think of it in 3 categories. DNA is sort of the archive book. mRNA is more like the printing press. And then our protein is the newspaper that comes out. Well, in Duchenne, we have an abnormality in a gene that causes our mRNA to have sort of a missing piece of that. And so the printing press is printing out either the wrong newspaper or not the newspaper at all because it can't make sense of it as the end product. Well, exon skipping medicines try to eliminate that gap in the mRNA so that the patient can still make protein that can still be functional. And so you still get a newspaper. It might be missing a few sentences or a few words, but you still can get the gist of it as the end product. And so we're seeing benefits of patients' skeletal muscles on exon skipping medications if they qualify. The question is, will their hearts also benefit? And we would think, yes, it would, because the same genetic process is happening in the heart as it is the skeleton. But the main issue is making sure this medication, as it gets delivered through the IV, actually can penetrate the heart and do this process in the heart muscle. And so research is going on coming up with various cocktails of these exon skipping medications that allow it to penetrate the heart so that it can do this process and skip the exons and make protein that might be better than no protein. Just a quick slide. This is a few years old from one of my partners, Dr. Markham, just to talk about all the research going on in Duchenne's muscular dystrophy. This isn't even all of it, but I just want people to realize just how much effort is going on across the country, and certainly more needs to be done until we cure muscular dystrophy across the board. And one final plug I just want to make sure everybody's aware of is carrier females. And so patients with specifically Duchenne and Becker muscular dystrophy, mothers or females in the family can be carriers of it. So we know 70% of patients with Duchenne muscular dystrophy that they got that genetic abnormality from their mom. So one of the abnormal X chromosomes that came from their mom went to the son, or rare occasions the daughter, and they don't have enough of that dystrophin. And so of that 70% that comes from their moms, 60% of those moms can develop heart disease as well over the span of their lifetime. It tends to be much milder, tends to be a little later in life than we see in the males with Duchenne's muscular dystrophy, but it can happen. And so the short purpose of this slide is to make sure all carrier females, or those with unknown carrier status because they haven't got genetic testing, need regular cardiology surveillance. And that typically means getting at least an EKG and an echo. And if things look normal, then periodically repeating that every 3 years or so. And so making sure that you know that. And then of course, if you get screened and you have cardiomyopathy or heart muscle abnormalities, making sure that you're seeing a cardiologist who's versed in taking care of patients with that is very, very important. And so conclusions, the heart involvement is very common in all forms of muscular dystrophy. Almost all of them, with a few exceptions, we assume will have heart involvement. It's just a matter of how we do our surveillance program. It determines how often we see them and what tests we do at each year that we follow them up, or each 6-month period that we follow them up. There's good treatments that exist. They're not perfect, but they're better than they were 20 years ago and even 10 years ago. And these treatments can actually improve the quality and longevity of patients with muscular dystrophy's life from a heart standpoint. And a big topic, I think, is optimizing your overall health with nutrition, mitigating risk factors like hypertension, hypercholesterolemia, and making sure you're seeing your other specialists, because making sure those organs are healthy helps the heart out. And female carriers, as I just said, need to be followed. And so I'll end that and stop my share here and open up the floor to any questions. I see one question on there I think I can read out loud for everybody. It says, can muscular dystrophy cause heart abnormalities and dysfunction without showing fibrosis on an MRI? And the answer is yes. And alternatively, the alternative answer to that is, can you have no dysfunction and no heart rhythms and have just scar? And that can also happen. And so that's why I think a lot of centers are moving to sort of alternating echoes with MRIs on a patient once they get to an age that they can lay flat and still for it. And so most patients, that tends to be the earliest I've ever done an MRI on a patient and not required general anesthesia, which is a big piece of this. We don't want to necessarily put a 5 or 6 year old under general anesthesia for an MRI when we know the likelihood of finding something is exceedingly low or almost zero. So we want to wait till they can lay flat, and that can be as early as 7 or 8 years of age. The average is probably around 9 or 10 years of age, and some patients, like we talked about earlier, can't ever undergo an MRI. But it's an important question, and we really want to find the earliest stage of heart disease, because we have various heart medicines we can use to start changing or slowing that process down, whether it's eplerenone or aldactone or ACE inhibitors or beta blockers. How we treat that depends on what we're finding either on the echo or the MRI. And so I think that's a really important question that you brought up. All right, well, I want to thank everybody again for their time, and Kristen for arranging this and helping me get everything prepared for this. I appreciate it. Thank you.
Thank you so much, Dr. Parent. We really appreciate the time you took to come today. And we thank you so much for all that you do for the neuromuscular community. So thank you so much.
Thanks.